Okay, this is we are just on time. So
Yes.
this is our second webinar, and everybody's very welcome. And the topic today is movement disorders. And we have the honor to have Elena with us. So let's start.
Okay, if you want.
Paulo has to present you, Elena.
Okay.
Let's start. Now I'm right. Welcome to everyone. I would like to thank all for being here today and say how important your participation is. Before starting our webinar, let's all agree how to ask questions and comments today. All questions and comments will be made after presentation of Professor Elena Moro and the comments of the panelists, Professor Yuri Souza and Eric Fonoff. Questions and comments can be sent by clicking the Q&A icon. We will use a quiz test to ask some questions about your experience to many characteristics of brain surgeries for movement disorders. Well, let's start now. Today's topic certainly interests us of all, because even with the most current pharmacotherapy, many people who suffer from movement disorders are refractory and need treatment with surgery. Today's guests, we have selected an important group formed by professors and heads of neurological and neurosurgical important hospitals. The panelists invited today are Professor Eric Fonoff and Yuri Souza. Dr. Eric Fonoff is an associate professor in the Department of Neurology, University of São Paulo, Brazil. Dr. Yuri Souza is head of Neurosurgery Department, São Rafael Hospital, Salvador, Brazil. Professor Elena Moro is director of the Movement Disorder Center in Grenoble, France, as well as head of Department of Psychiatry, Neurology, Neurological Rehabilitation, and Forensic Medicine. Dr. Elena Moro is a neurologist with multinational and multi-continental training and experience. Dr. Moro's main interest to understand the mechanism of action in DBS through clinical research, improving clinical results, and developing new surgical treatments. Many thanks to everyone for accepting the invitation for the Brazilian Society of Functional Neurosurgery. Professor Elena Moro, the stage is yours. Break a leg.
Thank you, Paolo. Thank you very much. I thank you and Antonio for and all society for inviting me to the opportunity to share with you some reflection of the state of art of DBS. And we have already some questions, and I think I will answer some of the questions that have been already asked. And eventually, you know, we will complement the presentation with your comments and your questions. So I asked Paolo to change the title of the presentation that he asked me, because we have several new things that are coming in the fields of DBS for movement disorders. And I thought that to go through all this, what we have now and the future can help us also in organize our, our clinic and our future as a clinician and as researchers. So I will start with share my screen with you. So the desktop, and then I go through the presentation. Let's see if it works. You should see now. So the update on DBS. Why that? In Europe we are almost finishing the pandemic, but you will see why I put one slides about the COVID-19 pandemic. Then we will go through some clinical data. We just published something about long-term, and I might share with you some new stuff that we are under submission. Update on the targets, programming strategies, devices, and new developments. I don't know, but maybe you neurosurgeons, you have not been so stressed by neuro-COVID patients, but at least the neurologists, we have seen some complication linked to the virus. And also we have changed our practice a bit like you are doing, more probably in Brazil, with the almost urgent cases. And you know very well that the DBS cases have been basically stopped during the pandemic, just replacing batteries because it's an urgent matter, but the classical DBS surgery has been stopped. And the pandemic has really increased quite a lot in the way that we are doing now the telemedicine, right? So we have developed some recommendation. This is from the European Academy of Neurology, how to deal with patients with Parkinson's disease during the pandemic. They're very general comments. And also I want to point your attention, this is a recent letter published on movement disorders with the new device that the Chinese have, PINS. With this device, basically you can program a patient from your office and the patient is at home, like the cardiologists do. And I think that they took advantage of this time to stress that with this device you can do that. Well, we know that we can do also with the groups, but I think that probably in the next future, almost all the devices will have also the ability that you can program the patient from your office without having the patient coming directly to see you. So is DBS still fashionable? You know, we are having all this information about FUS, the focal ultrasound lesions. Well, I think that these graphs from a recent paper from Andres Lozano shows you that the literature and also the research linked to DBS in general is going up. I mean, I'm reviewing so many papers about DBS, so there's no point that DBS is still a fashion, is still the main goal of patients with movement disorders. We will talk eventually about tremor a bit, but Parkinson's disease, dystonia, DBS is the best choice up to now. And this is the other paper, I think that if you want to review it, is a sort of state of art, what is under investigation with deep brain stimulation. And you see that we have different phases of the clinical trial. Is not only movement disorders. You know very well that Andres is focused on depression and also in Alzheimer's disease, but I think our psychiatrists are interested in finding something different from schizophrenia and addiction. Addiction is a big problem to drugs, to alcohol, but unfortunately we are still very far, right? You can see that is the trial phase 1, phase 2. So then anorexia as well. So it looks that the interest for neurologists is always very high, but I hope that in the future our psychiatrists, the colleagues, will be more interested in treating some disorder using the brain stimulation, and you have a summary of the some targets that are undergoing. But what I think is much more relevant now after how many years of DBS? 35. So is the long term. And why is the long term of the data? Because I don't know how many patients you see with Parkinson's disease, but in Europe, we are bombarded. Neurologists are seeing, and in their practice, 50% of the patients coming to their office have a neurodegenerative disease, or Parkinson or Alzheimer, because they're getting old, and this is the reason. It's much more, they are diseases that increase with age. So our residents will see tons of patients with Parkinson's disease. And in the same time, you see that your patients are getting old. They live much more than when they used to live years ago. So what we are seeing that these patients, they will have Parkinson's disease for 20, for 30 years. So it's normal now that we ask ourselves, if we do DBS surgery when they're 60, 65, how long the results of DBS will stay? So if you read the literature, this is a summary paper from Patricia Limusen and Tom Fontini. There are not so many reporting after 10 years, for example, DBS. There are very few. But what strikes you, this is with DBS on and off medication. You see that the before surgery is the blue, and the others belongs to after surgery. You see that roughly at 10 years after surgery, there's still a benefit in the off medication state induced by the stimulation. So we can say that in the long term, DBS gives still a good benefit for our patient when they are without stimulation, we can see. But over the years, we know that disease is progressing, so they lose the initial benefit they had in the immediate postoperative phase. You can see that in red, in blue, the light blue is before surgery when they take the medication. And after more than 10 years since the surgery, the on is less good. But this is normal because the disease has progressed. So we don't demand the STN or the GPI to keep a good on all the time, because we know that is a symptomatic treatment, and with the progression of the disease, the symptom which normally respond to levodopa, they will respond less. So it's normal that over the time, the response to levodopa slows down. This is a paper that we just published in Neurology. And I think it's very important for two reasons, not because it's coming from our team, but because it's the first time that you have a pool of 100 patients. All the other paper, they are 20 patient maximum. We have 100 patients with at least 10 years follow-up, and we studied dementia in these patients. The question is DBS in the STN increasing dementia in patients with Parkinson's disease? Why is relevant? Because I'm sure that you read some papers and they say that after surgery, you worsen some cognitive issues. So in this paper with 100, we didn't see it. So the dementia was at 10 years, 30%, 25% of our patients, which is according to the normal population of patients with Parkinson's disease who don't have surgery. So that means that DBS does not accelerate dementia in patients with Parkinson's disease, which is a good news, because our patients will ask you, do I become demented if I do surgery? No. But what are the predictors of good outcome in terms of cognition at 10 years? So good outcome are, you should be a female. If you are a male, the risk is a bit higher. A little young, not too old when you have surgery. You should not have a hallucination before surgery, and cognitively preserved. So these are the predictor factor of good cognitive outcome at 10 years of DBS. But if you have some troubles during the surgery, like a perioperative bleeding, that is bad for you, because there is a high risk that you become demented at 10 years after surgery, within the span of 10 years. So I thought it was a good thought for you, because the patient will ask you, right, if you increase the risk of having dementia with this kind of surgery. And these are from the paper, the curves of progression for dementia. You see that the risk factor that we mentioned, to be old, to be a male, to have hallucination, a high frontal score, they will impact the risk of dementia. And in this, on the right side, you will see that this is the prevalence of dementia when you have Parkinson's disease, and several years of Parkinson's disease was actually very high in a population without DBS. So definitely, just to confirm, DBS does not increase the risk of having dementia. The other hot field in DBS are the non-motor symptoms, because everybody knows that the DBS is good for improving, we saw the review, tremor, bradykinesia, rigidity. But what's about the other non-motor symptoms like sleep, urinary disturbance, mood, gastrointestinal problems, pain? What does DBS do? So there are some articles also in some book chapters. This is a recent article, was published a few years ago. So I just put for you to, if you like these fields, just few key points about that. So this is a paper 2 years ago. They studied, it was really designed to study non-motor symptoms in Parkinson's disease after 2 years of STN-DBS. So they don't have too many, 67, but what I show you in these graphs, you see that the symptoms with the star were improved after 2 years after surgery. So cardiovascular, like hypotension, sleep, fatigue, hallucination, constipation, other gastrointestinal points, and urinary issue were improved after DBS. And this is another important point, because patients, they complain quite a lot about the non-motor symptoms in Parkinson's disease. And this other paper that I like, and you might already heard from me talking about this, is pain. So pain in Parkinson's disease now is another good topic. You can hear a lot from neurologists talking about pain. What's about pain and STN-DBS? So this is from South Korea. They say, you see these graphs, this is the pain score before surgery, after surgery. It looks that is getting higher. The patients are getting worse. But the reason why actually the pain is getting worse after surgery is not the dystonia, the Parkinsonian pain, is the pain related to arthritis. So these patients are getting older, so the pain is the arthritic pain, is not the pain related to Parkinson, which improves. So this is another point. The pain related to Parkinson can be improved and not worsened by STN-DBS in the long term. And why is that? This is a paper from our colleagues from the Grenoble Institute of Neuroscience. They are basic neuroscientists studying the STN-DBS in rats. And they found that rats has a circuit of pain circuit which involves the STN. So if you stimulate the STN, you have some pain relief because there is a pain network which involves also the subthalamus. So the reason why may be that when you stimulate the patients with the STN, the pain improves because we interfere with this pain network, which is also based in the STN. It's interesting, I think, this point. So the other very poor study symptoms in patients with Parkinson's disease is dyspnea. Sometimes the patient complain about, some shortness of breath, they're not doing well. So we study this in STN-DBS patients. This is another paper that just came up. This was from patients in Toronto. These patients with STN-DBS, they were complaining about shortness of breath after surgery. So we studied them comparing with patients who were not complaining about dyspnea. We did some pulmonary function in both groups, and we didn't find any difference in the pulmonary function. So the hypothesis is that maybe there is a small interference when we stimulate in some a little higher with the voltage, and they might experience some subjective sensation that there is a shortness of breath, but there is no functional changes in the objective pulmonary features. But the other interesting thing that it comes with this paper is that when you give the patients the questionnaire about breathing, they discover that, well, actually I have some dyspnea, but I never thought about that. So that means that there is another non-motor symptoms that we need to explore in a patient with Parkinson's disease, because it can be neglected. So just moving on, just going to more technical stuff. So we all know that the limitation today, besides the good things that we talk just up to now about DBS, we have side effects induced by DBS. We know that, no? This dysarthria, for example, dyskinesia induced by DBS, some freezing of gait induced by DBS. And the other question is, why not all patients are doing well? Now, the electrode looks in the right place. Maybe the neurologist, I trust the neurologist, the patient was a good patient for surgery. And why they're not doing it the same way? The outcome is different. And then we said about that over the years, they lose some benefit from the axial signs that they had soon after surgery. And we know that there is no neuroprotection with this treatment. And we know very well, you know very well, that we have some device technical limits, right? That unfortunately we have to deal now in our practice. Let's go through some of these points. So the side effects, as I said, one that bother us, most of the patients and the caregivers, the speech. No, the speech can also become much worse, and sometimes it's very difficult for us to improve it. We talk about gait and balance, freezing, they fall a little more after surgery. The dyskinesia might be difficult to manage, or the dystonia. So if the electrode touches the pallidofugal fibers, we can block the effect of levodopa, which is quite unpleasant. Then we have apathy. Then the patient can put on weight. The patient is not happy. The family, but I thought that the patient could be cured, whatever. So most of the time, this issue, they come now together with maybe not an optimal electrode position, but not always. Sometimes it looks that everything was perfect, but the results are not so good. So this is the reason why, and you see Rubens from São Paulo, who participated to this paper that we wrote together, we try to find new targets. Right? There is always, it's good that we have all this hope to find a better target for our patients. So what are the targets that are most appealing now? So in the past, I will say in the past, because it looks that it's out of fashion, was the pedunculopontine nucleus, right? So we're still, and I'm sure that Eric maybe is still doing some of them, but definitely not all the patients are doing well. So there's something wrong there. We don't know. It's not the time to talk about that. But the PPN now is a bit out of fashion. Very few centers, even Tipo Aziz, he told you that the last PPN was 1 year, 2 years ago, right? So that means that not, is not the best candidate today. But there are the interest in the cerebellum and the dendrorubothalamic fiber, for example, for tremor. This is one. For all the dentate nucleus, we will see for dystonia, there is some, we will go through 2 papers that they come, and also you in Brazil, no, had some experience with that. Then we have the substantia nigra compacta or reticulata that we try to target. There are some papers about that. And then we have the spinal cord. There is a huge interest, and Eric can add make some comments. He published papers about that. No, so these are some new or rediscover, and also in the centrum medianum in the thalamus targets that we try to see if they can give us something more than what we have now. And the minor nucleus, you know that there are 2 publications about that, not particularly attractive, but it can be possible to limit dementia in Parkinson's. And just to go through some that has been published from Spain, the idea to stimulate the substantia nigra reticulata together with the STN with different frequency to see if we can improve gait issue better than just stimulating the STN. So the idea is also now to stimulate together in the same time 2 different structures, using in this case the 8 contact electrode, for example, or just placing the bottom of the lead with the highest space between the contacts, one in the bottom in the substantia nigra and the other spanning through the STN. For dystonia, I found by now published, maybe you are better than me, 2 cases. One is from San Francisco, and the other, I think, is from Japan, in which they try for dystonia, was secondary dystonia, unilateral to stimulate the dentate. And in this paper, of course, they're open, their case report, the benefit was substantial. We will see, I think, in the future if this can be a target maybe for secondary dystonia better than the pallidum that we have now. But the cerebellum is still, for dystonia is really another hot topic that we were talking about before. We will see more in the future. And the spinal cord, So the spinal cord, you see Eric there, Clement, so they think in this nice paper, they summarize the rationale of translational research from rats to humans. So this paper is some of summary and what is being published, right? I didn't put everything, Eric. I just wanted to stress, maybe you will find me nasty, but follow me. So in this paper is a research article, you see it, a research article, 2018, so 2 years ago, from Canada, because the next paper is from Canada too. You see that they had 5 patients with Parkinson's disease, and they did spinal cord stimulation, okay? I think it was mostly thoracic, okay? And you can see that they have fantastic improvement. So 38, roughly from 40–50%. And also in the freezing, a lot of improvement, okay? But it's an open trial, okay? It's open. Everything, is done 6 months. Everything is fantastic, okay? That's why we say, wow, that's so good. And my colleagues, Paolo from Rome, spinal cord stimulation can also improve everything. You can even become smarter, if you do this. You can also improve dysautonomia. This another target can be excellent for improving everything. 12 months after implantation. Of course, these are 12 patients, open studies, okay? But you see, not everybody is happy. This is a letter. So as a negative results published, this is Toronto, okay? So it looks that when you have a good results, you have an original paper. If you publish bad results, you just have a letter, And this was with more patients and followed for 1 year. Okay, there are 6, the other were 5, and they didn't find any improvement. It's true that maybe you can say, well, it was T10 level. You know, Mazzone puts the electrode really very high, cervical level. But, you know, I think it was done with the same property as the other paper. But, you know, negative results, you just get a letter. Sorry about that, but this is unfortunately a bad thing to say. So we will probably in the future have a little more papers about that, and Eric can comment later. But personally, I think that is an appealing target because it's easy for you also, for us to, to propose the patients, much less invasive. And I think it deserves a little more attention and more studies. Another problem that we have is that which device we have to choose. So in Brazil, I think you have 3, right? Like us. In Europe, we have 3. There is one company in Switzerland. I think they have, so in Switzerland, you have 4. And in China, I think there are at least 2 other companies. Okay, so how do we choose this device for our patients? So this is a viewpoint from Michael Okun. I don't know if he gives us this solution, but he compares the 3 available in the United States, and I would say in Europe and also in South America, devices, Medtronic, Abbott, and Boston. This is a sort of summary of the characteristics, and we will go through. It's not easy. Because we are not working for Medtronic, Abbott, or Boston. So we have to be above. We are not employed by these companies. So we have to try to be rational when we support one or the other. And it's not easy, right? Because I might prefer, I don't know, Medtronic because I know them. I know that the material is very good. I'm very familiar with the material. But, and also you can have MRI. But you can say, well, yes, but with the Medtronic, I can't use all the independence frequencies. So if maybe I need, I can use that one. Or Medtronic doesn't have yet the directional. The other 2 company have the directional. If we don't have evidence, right, that one is better than the other one. So it's difficult. I think that today, personally, I find it difficult when, I choose between the systems. And we don't have guidelines, and we will never have the guidelines about that. So I think it should be an ethical reflection sometimes now to think why we choose one and why we don't choose the other ones. But today, there's no evidence to tell us you should do this or the other one. Is I think, left to the centers, the experience that they have with the stimulators, to implant and to decide which one is better for one and not for the other. So going through technology, we said that to have a long electrodes might be useful if you want to stimulate more targets at the same time, and to have the ability to choose one frequency, one contact, and one in the other can be useful in the example that we showed if you stimulate the substantia nigra and the STN at the same time. In the GPI, we don't have a lot of studies. I remember I saw one about Huntington disease. It was not really convincing that if you use stimulate the GPI and the GP together, you can have a better benefit. But I think that research can be done in this field. And the directional. The directional, Europe and Germany, the directional lead have been there for years. And there are not a lot of publication. It's surprising, right? That we don't see so many publications. And the idea of the steering, very well, is quite clear. If you use, the classical circular, you can stimulate the internal capsule. ideally, if you steer the current towards your target, you know, you spare the side effects that you might have using the same energy that, as you see here, no? This 2 milliampere, you can avoid the capsule with the directional. And you can see the concept, no, nicely summarized in this figure. This is the sweet spot, this is the bad one. In the circular mode, you are stimulating, you know, the two things. And if you use the directional, you can find a way to avoid the bad area and just use the good one. And as I said, there are not a lot of papers, right? So they're mostly are coming from Germany because they have the longest experience. This is in 2017, in which they show that you can have a better, a wider window, therapeutic window. So you can use the same current and have less side effects. So this is one paper. There are others, but there are very few, and there are very few cases, you know, they don't reach more than 10 patients with this new technology, which is quite sad, I think. But you know the reason, because it's very time consuming to do this kind of studies, good studies. So basically we use them, but there's no big evidence, you know, coming today from this paper. But this, the proof of, you know, we will talk about some beta and the closed loop stimulation. The idea is also to use the directional to have a local field potential. It is not so difficult to record. It depends, you can have good quality. It depends on who is recording for the local field potential, but ideally also with the directional, you can select the best area in the brain where you have much more beta activity and try to use this contact to focalize your simulation. These are proof of concept articles. And that is the next step. Why we are interested in closed loop stimulation and the leads that they can capture the beta activity. But this is not new. You all know the research that Peter Brown and Alberto Priori they've done, in which they say that basically the hallmark of Parkinson's disease is this beta activity. So we don't talk about Parkinson, we talk about oscillopathy. Parkinson is an oscillopathy. So it's because there's too much beta activity in the basal ganglia. This is just very strong to say, but this is actually what we are recording from the electrodes in the Parkinsonian. And these are nice paper from the German school. It looks that the beta, indeed the beta power activity is localized in the dorsolateral part of the STN, which is where we live our, we stimulate in the sweet spot to have the best improvement in the motor sign. And you have less beta activity in the limbic area and the associative area. You have other kind of activity there, usually is lower, right? So the beta activity is more concentrated in the motor part of the STN. And you know that the beta activity disappears when the patient has levodopa. When the patient has levodopa, we go more in the gamma activity and dyskinesia. So it looks really that Parkinson on is gamma, Parkinson off is more beta. And if you stimulate in the STN, this beta activity goes down. So the STN suppress this, DBS suppress this beta activity and improve motor performance. So we have more information. Beta activity is bad, but STN is improving. Is stopping this beta activity. So why we don't use a system that can read this beta activity, the electrode can read this beta activity, and I can stimulate the patient on demand. When the patient is off, tack, the stimulation starts. When the patient maybe takes a little of levodopa, the activity the beta goes down, it appears a gamma activity, and the system adapt and reduce the voltage of stimulation. And this is the idea of the adaptive. And Brown showed that this idea is very good also for dysarthria, because in this way, the brain is not stimulating all the time. And the concept of maladaptive stimulation, when you stimulate too much and you have dysarthria because the system is too much stimulated, if you use this concept, you might avoid the side effects of stimulating your target. And also, this is from priori, because you reduce the unneeded stimulation, you can improve dyskinesia with this kind of system, a closed loop system. And this is the new device that Medtronic is available in Europe now. In Europe, it costs a little more than the Activa. And this looks at the promising product that is the sensing, right? So it looks that it's smaller than the Activa and thinner, and the expected life looks prolonged. And you can use, at least in Europe, in all the Parkinsonian and also in epilepsy and OCD. And you will see it. So this is basically you are able to see the beta activity and to record for also a long time in bipolar setting this activity from the brain of your patients. You can't adapt by now, you just record, but you can have information about your activity. If you can also decide if you believe to program your patients just recording from which electrode you have a much more beta activity and start the stimulation of a mosquito going around. So this is just to show that the technology is really now moving, maybe because the competition is not pushing. So let's go through new technique, and then I will stop very soon to stimulate. We are used to the classical regular frequency stimulation. Why we don't use intermittent theta burst stimulation? Why that? Because there are some studies that they show that in the cortex, the theta power is related to cognition. So if I can stimulate the STN, for example, and modify the cortical activity in the prefrontal cortex, I might increase the cognitive performances of our patients. So this is what they did. They stimulated with a different type, as I said, the intermittent theta burst stimulation, and they found that they could increase the theta power activity in the dorsolateral frontal cord. They put a strip inside the cortex to record, and from the STN they use this intermittent theta burst. And they show that they could modulate the activity of the cortex in the same way as Philip Starr is a bit doing to study what is going on. So in the future, maybe we will see this kind of new ideas, strategies. We have to show if they're effective, but just to show that the interest is to find new way to use the programming. And this is what they did. For example, in this group from Germany, they used the theta bar stimulation just to prove that not recording from the cortex, that is not bad for the patients. So for example, they found that there were no big changes using this theta burst in the clinical signs, in rigidity, in tremor, and in bradykinesia. They was not better, but at least they didn't worsen the patients. And this is the program, the paradigm of this trial, if you are interested in understanding this. So going to the end, the other trend now is to use neuroimaging, because we can see this disease like a circuitopathies. No? So we know that the concept is Andres talking depression is a circuit problem. Also Parkinson's disease is a circuit problem. So we can use the brain connectoma, no? So trying to have the functional connectivity, the structural connectivity, building maps, and see which good maps is related to the best outcome when I stimulate the brain. So these are other techniques, again, that they can help in programming the patient and also in the selection of the patients. And why is that? Well, I think that this technique, they can also tell us a little more about the mechanism of action of DBS. This is another nice paper from Andres summarizing with a nice picture what we do when we stimulate the brain. No? The classical theories that is a direct inhibition, direct excitation, a jamming thing, a synaptic filtering. But with this mapping, maybe we can also see in a different way. This is a paper from last year in Brain, and basically shows that DBS can change the connectivity. No? You see that DBS off, you have this mapping. With DBS on, sorry, maybe I small with this, you have this kind of mapping, as is much more similar to a normal people. So in this case, we can see that DBS is able to change the connectivity of our brain network. Sorry, let me move on. So take-home messages. I think that, again, no new, but we are comfortable in saying that in the long term, DBS is still effective for dopaminergic responsive motor symptoms, and potentially effective for non-motor symptoms. And at least in the long term, you can say that it does not induce by itself dementia. You see that there are some exciting things going on about the targets. The adaptive DBS looks more a trend now. The directional, are there, but people are maybe seen for this adaptation with this closed loop, and maybe some other technology like the little devices that you have to check the gait, the classical watches, and other devices that can inform the brain on the real state of the patients, and the connectivity that can be used for understanding the mechanism of action, and also maybe to select and to program better our patients. And with this, I finished. And just to remind you, this is the Grenoble team with a lot of women neurologists, still the two men, the neurosurgeons, still alive, and one man is in one of our physiotherapists and one of our research assistants, the neuropsychologist, our nurse, another physiatrist, and our researcher in GATE, Bettina Debou. And I want also to thank all the fellows and the residents and the students. So thank you for your attention. Now I will give you back my screen. Paolo, you have to switch on your microphone.
Okay. Just before to start the discussion about your topic, I would like to stress that there is no support for the industry for this discussion. So everybody's completely free to show their opinions about everything, okay? So Paulo, take the lead now.
Okay, thank you, Antonio. Elena, you did it again. Congratulations, very elegant. Thank you very much. Now I would like to call our panelists. I asked the professor to pay attention to the time. We need to maintain our honor. Dr. Fanoff, please, 5 minutes for your remarks. After then, Professor Yuri.
All right, thank you very much. I think I will not take that much. So, well, I'd like to thank Elena for a wonderful presentation and this overview about DBS. We do know that she does have some conflicts of interest because she's enthusiastic in DBS. We know that. So, so as we are, of course. So it's very nice to hear that the field is advancing and together with the technology. So I'd like to ask her. She talked about very quickly about the new techniques or the new technology, the directional and the sensing DBS that are coming out. I'd like if she can give us some of your thoughts, of her thoughts on the directional, if she has some experience and an opinion. If you know, I'm sure you have an opinion on that. Even if not many cases, we all have some ideas, and also the perception. We have no, we don't have this available in Brazil, so we are very excited to hear about that. If you have any patients already implanted, it would be nice to hear some details from you. Can you do that? And if you want, afterwards, we can talk about the spinal cord stimulation, but I don't think this is the time. There's time for that.
Yeah, I will be very quick. So we are much more experienced with Boston rather than Abbott for several reasons, but I don't think that there is a big difference. So the direction, I think, can be useful when we have troubles with probably when the location is not really perfect. I have to say that we have in our patient with the directional, we actually use them less than 50%. So because the usual conventional stimulation was better. So I think can be useful, no? Like all the technology can be useful, but they, if you really, the electrode is not well positioned, they're not useful at all.
All right.
Exactly. But I think.
Do you have any? Sorry. Do you have any experience on GPI?
We have not implanted because again the GPI is big, right? So when you use the directional, is smaller the area that you are stimulating, and so we didn't use so far the GPI in the direction and the GPI. The closed loop stimulation, I think is very new, right? So we knew the concept because Peter Brown has been talking for how many years, but the technology was not there. Now we have the technology and we have to prove that this is really useful. As I said, it just came up. I think is interesting. The idea is interesting. If it's really changing the way that we are implanting, we don't know yet. We have to prove it,
Thank you, Elena.
Well, but this device is not closed loop yet.
No, it's not closed loop.
You think it is?
Is not. You're right. It will be the next step.
It does not offer closed loop.
But it has to prove you that is right the concept. No, the beta activity is really useful.
Sure.
So far, there's they are research. We have to prove it that they're really useful.
Just a time question. Dr. Erki? Any comments more?
No, I think this is the our perception also. Of course, we don't have any experience with the Percept yet, but I even think that it would be very nice to have the both technology in the same device in the future. So
Yes.
this will be quite interesting. Yes. If technology helps us with that, we'll be very pleased with it. No more comments because of the time. I would have many, but.
Okay, thank you very much.
Thank you, Elena. Thank you very much.
Thank you very much for your time, Professor Eric. But keep going with us, please. Dr. Yuri Souza. Dr. Yuri, are you here?
Yes, I'm here. I had some problems in the last
thank you.
10 minutes of the talk, but I'm back. Thank you, Elena, very much. You are for sure a member of our society, the Brazilian Stereotactic and Functional Neurosurgery Society. You are one of our biggest allies for sure. It's always a pleasure to see you talking about Parkinson's disease, about deep brain stimulation. And thank you very much for sharing your expertise. Just highlighting some points that for me was important in your presentation. First of all, the slide about how hemorrhage during the implantation of DBS can be a cause of dementia. Interesting that when you check the overall curve, you see that even after 5 years, they still keep getting worse compared to themselves some years before. That's not my impression. I think that when a patient has some social complication, usually after, I think someone has the microphone open and some noise. So if you could please close. So it's interesting about that, this idea. The only thing was very interesting for me when you said that, and this is a very, very clinical detail and super nice. Thank you for sharing, but you need to explain a little bit better. When you stimulate the palidofugal fibers of the GPI, the patients can get an effect that decrease the effect of the levodopa. So when you think anatomically, where is this? Is like when you're stimulated a little bit more anterior and higher, or when you see this, what do you think in your head? Where am I in terms of stimulation? That's one question that I have for you. I have other questions. Maybe you can start with these ones, but thank you very much for sharing your knowledge. The walk is a big problem for me. It's another thing that if you have something that you like to share, walk in dystonia is always a problem for my patients. I have seen patients during the COVID here in Bahia. We are just passing the curve, and the Parkinson patients are coming back with really big problems to walk. I think during this period of time, they stay more at home, they stay more closed. So I examined them. They are doing very well after DBS in terms of tremor, in terms of bradykinesia, in terms of rigidity. But the walk of these patients are really bad during this time now. Do you have any thing you'd like to share with us how you can improve walk in Parkinson patients? Considering that you have the clinical standards, not like in terms of research. Yeah, that's it. The palidofugal and levodopa action and what you can do in terms of improving the walk of the patients right now in terms of clinical strategies.
Yeah, thank you. So I will say that probably the palidofugal are more posterior and dorsal, no, if you can say. And it's very rare, and I don't remember which was one side. Probably it's one side all the time. I think I saw this twice or 3 times here in Grenoble, and once in Toronto and once when I was in Italy. So we don't see it very much, but it's a big issue because basically you stop any benefit from levodopa when the electrode is on. Then you stop the stimulation, and the patient, they start having dyskinesia and talking. You turn the stimulation off, and basically they're frozen, right? So under levodopa, under levodopa. So it's quite an interesting, rare side effects. Thanks God. The gait, you mean patients with STN and gait problems? Those are the challenging. And you know very well that we try different frequency. We try to go low 80, 60 hertz for no reducing. Probably this is the maladaptive stimulation. I don't see any other reason why we should see that in the long term. They're not all the patients, I would say there's a minority. It becomes challenging, and I think this is what we said. These are special people. The outcome, there are people we don't know, maybe genetics, maybe the mapping that we saw, the connectivity is different, and they have these symptoms. And what we do is try to use amantadine, to use other medication, and to reduce the frequency.
Right. Elena, 10 minutes more for questions. Please, we have many. Thank you very much for the audience.
We lost the audio.
We lost Paulo's audio. Huh?
Lost Paolo. Paolo, you're speechless. It's strange.
So I think he
Maybe
closed.
the applicant.
Paulo, are you still there? Maybe the connection is not so good.
Okay.
Otherwise, Paolo,
Can you hear me now?
yes.
No.
Yes.
Okay. First question. Some scientific works have pointed out the possibility, preventive action of DBS on the evolution of Parkinson's disease if it is applied early. Does this concept is currently taking account for the surgical indication?
No, no. So you know very well that today we don't have anything stopping, slowing down the disease. Nothing, no medication, just the antibodies, anti-synuclein are on the research study. We have this trial, we don't know the results. And DBS, definitely, I don't think we can say that is neuroprotective, because you know very well, when the battery dies, you guys have to change the battery immediately, because otherwise the patient will die. So this tells you that it's not neuroprotective, because otherwise the off should be much smoother and much better, and this is not. So it's not a neuroprotective. The anatomopathology studies published, they don't show any restoration in the brain.
Okay, thank you. It's another question, very similar, but why do the patients take so long to reach to the treatment center of movement disorders? Why, despite everything that is published and writing in the Association of Parkinson's, dystonia, tremor, many patients already come with cognitive symptoms in more than 1 decade of evolution of the disease outside the honeymoon period?
This is a very good question. It's an excellent question.
Yes, yes.
I think it's the neurologists, they have a bigger responsibility, because when they don't know, you know, this is the mea culpa, when we don't know exactly what does it mean, we don't suggest it. I think one are the neurologists responsible, because they don't do the interest of the patients. And sometimes the patients are also scared, right, to do the surgery. So there are different reasons.
Okay. Thank you, Elena. I'm looking for the quiz.
But I can answer, you are looking for the quiz. In the same time, I said that the study so far, and we are submitting the paper with patients with more than 15 years of DBS, 50 patients with more than 15 years of DBS, and the predictive factors of good long-term outcome are also the age at the surgery. So we should not wait too long to propose a surgery to this patient.
Thank you, Elena. I would like to send the first quiz test just to know about our audience. Is 10 seconds. Please, everybody with our now here with us. answer the questions.
So we have to click on the thing.
Yes. Now, okay. Like we preview Parkinson's disease, but essential tremor, and some persons don't believe. Okay?
That is a neurologist. He's a neurologist, I'm sure.
Yeah, like we talk.
Neurologist.
Yes, yes. Okay. Now, the next question, Elena, please. Okay. No. Okay. It's practical question, Elena. It's a practical question. To okay. What are the clinical parameters and how long after surgery is it usually safe to turn on the IPG and start the stimulation?
It's very practical. It depends on where you live. It depends on the patient. It depends on if the patient has a lesion-like effect. So there's no rules. You do whatever you think that is better for you. Just you follow your rationale. The patient still has the lesion-like effect. It's useless that you program him. The patient, you have to send the patient home because you have to pay a lot to stay in the hospital. You tell the patient, you know, you come back in 3 weeks and we start the stimulation. There's no rules. You adapt according to your practice.
Thank you. In the same way, can the impedance measure help you decide when you turn on the IPG?
No, because is the, and you are clinician as well, the clinical state of the patient is the one that is relevant.
Elena,
not impedance.
thank you. What was your first change in the prescription of medications right after surgery? Right after surgery.
So right after surgery, if the patient is like before surgery, don't do that. We start reducing the medication when we start the programming. And the first medication that we usually reduce, it depends. If the patient has a lot of dyskinesia, we reduce levodopa. If the patient had hallucination, we reduce dopamine agonist. It depends on the patient. But most of the time is the levodopa that we reduce.
Okay, the next questions. A common challenger is related to the stimulation-induced dyskinesia when the DBS electrode is well positioned in the STN motor territory. Under these circumstances, what is your recommendation?
Well, sometimes it's easy to manage, sometimes it's difficult. Most of the time, you can manage reducing levodopa, so that the dyskinesia will disappear slowly, or you can use the most dorsal contacts of the STN, which are almost close to the zona incerta, and you will have a much less dyskinesia, or bipolar stimulation at the beginning.
Thank you again. In bilateral stimulation, you can use 2 IPGs, each with unilateral stimulation, or one IPG that offers the option for bilateral stimulation. Do you find any advantage or disadvantage of these options, considering the indication for Parkinson's disease and dystonia?
I think with the new devices, I don't see the interest of doing 2. The new device rechargeable, smaller. Maybe you use, you know, the new device with different frequency, pulse width. No interest for me to do twice.
Okay, thank you. The next one. Considering the search for the best, Dr. Eric probably is the microphone open. Pedro, Eduardo, someone could help. Thank you very much. Considering the search for the best therapeutic effect with the longest duration, Is the monopolar or the bipolar configuration usually your first choice, Elena?
So in this paper that we have submitted with the patients up to 20 years of DBS, the monopolar was the choice, is the most important choice. So most of the times monopolar and forever, 20 years with monopolar stimulation. Long term, long term monopolar.
Okay, thank you again. Elena, another question. What do you recommend for the treatment of patients with PD, Parkinson's disease, and postural instability with falling, and when there is a VOG, refractory to levodopa?
Well, I think that Eric will give me a hug that I probably won't suggest the brain stimulation, maybe spinal cord. So if they're so bad, you know that the results from STN won't be so good. In that case, all the PPN, if you are able to do it, or the spinal cord. Even if there is no evidence, but there is no evidence also that the STN will work for these patients. Or you don't do anything, maybe duodopa, any other medical strategies, or the spinal cord or the PPN, but not STN.
Okay, thank you again. Their consideration is the audience. I think we can say that technological advances lead to a revival of functional lesional neurosurgery. It's okay. Do you believe that MRI-guided focused ultrasound telemotomy can be more advantageous than gamma knife?
Yes, definitely, definitely. Gamma knife, you know, when in Toronto, I had quite a lot of experience with Moji, was doing gamma knife, and Yuri remembers. The gamma knife, the onset of the benefit is after months, right? Up to 1 year, 2 years. Then the papers are very, you know, in some centers they work, in others doesn't. I think the focal ultrasound has the advantage that the result is right away. Tack, no, the patient comes out and everything is perfect. And you don't have radiation, you don't have all the side effects that they've been published. I think it's safer, the focal ultrasound, and it's faster.
Thank you, Elena. The last question, I promise, is very interesting for me, is about the genetic status of the patient with Parkinson's disease.
Yes.
The genetic status may show some difference in response of DBS. Would it be possible today to use genetic status in any way to access the candidate for DBS surgery?
So all the papers that they've been published about LARC, PINK, DJ mutation, the most common Parkinsonian mutation, they show that the results are the same. The point is the GBA mutation. The GBA mutation for you, neurosurgeon, is a mutation associated with Parkinson and dementia. So the patient with GBA mutation will become demented a little earlier than the other patient. So that can be a good reason why, if they do surgery, this patient, they should do surgery early. Because when they're demented, nobody will touch them, but the Parkinson will be aggressive. So maybe this patient with the GBA mutation should have DBS much earlier than the others.
Well, like we said in the beginning, everybody, thank you very much. I would like to pass the word, so I would like to call Dr. Antonio, our president of Brazilian Society of Functional Neurosurgeon, to last word. Elena, Yuri, Eric, thank you very much. Dr. Antonio, please.
Actually, I'd just like to thank you, everybody, the audience, the panelists. Elena, you did a really great job and very friendly. We know nobody here is having any support for the industry, so everybody's here just to share their experience and to share the knowledge about the movement disorders. So I have to thank you all. And see you guys the next week we have another webinar. Thank you.
Thank you very much.
Bye. Take care.
Bye.
Bye. Bye. Bye, everybody. All the friends. Bye,
Bye,
friends.
Elena. Thank you, Elena.
Ciao. Ciao.
It was bello incontrarte de nuevo. Grazie mille.
Italia. Thank you. Bye. Ciao. Thank you, everybody. All my friends.
Ciao, ciao.
Pleasure.
Thank you.
Bye. Bye. Bye.
Bye bye.
Thank you for inviting me. Bye.
You're very welcome.
Bye.